So one already. I'm going to go ahead and get started so folks can catch up as we move along. So welcome to the Center for the Business of Health Career Network's Fireside Chat, behind the scenes, navigating the business of United States hospital and healthcare systems with Dr. David Ballard, MD, MSPH, PhD, MBA, FACP. It's very many letters after his name, and Megan Berlinger, MHA, both of Solomon Page, which is a staffing solutions and executive search company. And again, they can explain a little bit more about that because I'm sure I just didn't do it enough justice. We're excited to have our presenters with us tonight. This is the first of two exciting sessions, and I'm going to go ahead and post the link to our second session. The second session will be Pathways to Leadership, Preparing for Success and Recruitment in U.S. Hospital and Healthcare Systems. That's happening next Tuesday, April 22nd, 6 p.m. So be sure to join us again for that second session. This fireside chat is a part of the UNC Center for the Business of Health Career Networks program. Career Networks is a constellation of resources meant to educate and create community around the continuously evolving healthcare ecosystem. You can explore the CBOH Career Networks platform via the URL that I'm pasting as well. And I'll paste all these again later on in case folks come in. For tonight's chat, we ask that you turn your video on and mute your microphone while not asking questions. Again, too, if you're in clinic or somewhere else where you can't, put your camera on, no problem. That's fine. The format of tonight's session will include a structured interview format with 2 Q&A pauses throughout that I'll indicate. During these pauses, we ask that you raise your digital hand if you have a question, or paste the question in the chat if you're unable to unmute, as again, we know that you may not be able to chat verbally. So I am so excited to welcome our guests. And so let's get started. I'll turn it over to Megan Berlinger and Dr. David Ballard. So off we go.
Wonderful. Well, we're so excited to be with you all this evening. And our goal is for this to be a conversation. And you'll hear, even though our focus is on the U.S. health system, this is more about the application and what we've seen throughout our careers. I'm really excited to be interviewing Dr. Ballard tonight as this fireside chat. And so let's just get started with, first of all, can you all see my presentation screen? Awesome. Let's get started with, well, let me throw an agenda out there first so that you all know the pathway we're going to take tonight. I want to start by asking Dr. Ballard what's driven him into healthcare and go deeper than his bio. And then we'll move into big picture, looking at, the delivery and payer mix, the how healthcare is administered, but what, not just how it is, but what that means to a career in healthcare. And then we'll move into the most important part of anything related to health is the impact on the patient, leading to what are those pressures impacting health systems and how are systems handling that. And then lastly, the second most important part is the impact on you all as part of this fireside chat. So with that, Dr. Ballard, let's get started.
And Megan, maybe before I introduce myself, why don't you introduce yourself and your background? Yeah.
Oh, I'd be happy to. I jokingly say I'm a triple Tar Heel. I had the honor of being in the School of Public Health for my BSPH as well as my MHA. And now I have the honor of being an adjunct assistant professor in the School of Public Health. Carolina has a very special place in my heart because of what all it trained me. I think growing up in a very strong university that believes of having diverse opinions in the room and really hearing all those perspectives kind of shaped me as to who I was. After graduate school, I went up to Hopkins for an administrative fellowship. I then returned to my hometown, which is where I live now still, Winston-Salem, North Carolina, to work at Wake Forest Baptist Medical Center for about 14 years. And then in January of 2020, believe it or not, that's when I started working from home in executive recruitment. And I've been in executive recruitment and teaching for the last 5 years. So just to give a little perspective, thank you, Dr. Ballard.
Great, great. And maybe before I have some comments, Suzanne mentioned if you have questions, but also, you have a lot of insights. You've thought a lot about healthcare. You've probably been patients. You've been, many of you are involved actively in healthcare organizations, and so we're interested in your comments as well as any questions you might have. Yeah.
Yes, I love how you've shaped that. And that's one thing I value about doing things within UNC and within the different schools, especially the business school. Well, to set the stage for tonight, to start us out, Dr. Ballard, can you share a little bit about your journey, especially what first drew you to healthcare and you bring such a passion? What's kept that passion over the years?
Sure. Well, I was fortunate. I had great parents. So I'm the sixth of 8 children. My parents were greatest generation Americans. They were both World War II heroes. My mother was a nurse in the middle of Europe for 2 years during World War II. My father was a surgeon. And so we had a lot of dinner discussions, not only about my father's practices, as a throat surgeon, about my mother's experiences during the war. And so it's not at all surprising that children 3 through 6 ended up going into medicine out of the 8 children. So I was exposed to care in my father's practice. I was exposed to the high touch of care early on. As a 15-year-old, my first paid job was as an orderly at Good Samaritan Hospital in my hometown of Lexington, Kentucky. So I had a pretty good idea that I was interested in healthcare. But what evolved over time was I realized that I was involved with I was interested in the big picture of healthcare as well. So I'm from Lexington. I went to one of the Moorhead nominating schools, the Lawrenceville School, and despite the recommendations of all my mentors, I was the first person in 5 years from Lawrenceville to accept the Moorhead Scholarship. So I studied economics with a health economist named Roger Feldman at UNC. And one of the things about economics is you all appreciate is the concept of scarcity. And I recognize that, a big challenge of healthcare is how do you allocate scarce resources to optimize the health of the population? And some of that has nothing to do with healthcare. So I thought pretty deeply about healthcare as an undergraduate. I spent 6 months in the British National Health Service for my undergraduate honors thesis in economics on basically the economics of domiciliary visiting or home visiting through the King's Fund Exchange. And so I was pretty sure when I was finished as an undergraduate that I wanted to do something in healthcare that related to groups of patients, populations of patients, and I also had an interest in clinical medicine, but I didn't know how those two were going to connect. My father, one day doing rounds with him, he says, son, you need to figure out, are you going to support the administrators or the doctors? And I said, well, Dad, isn't it really about the patients? And so one of your questions is in the group here is, what do you do if you're a healthcare administrator and you don't have a clinical background? And we talk about that some more later, but basically you get involved with clinical care. That's what you do. You do rounds in the hospital, you contribute to achieving clinical goals. So, maybe to give you just some small snapshots into other things that kept me passionate. So, after UNC, I applied early decision to the medical school. Was fortunate to get in at UNC, and over 5 years I did a master's in public health, a PhD in epidemiology, and an MD. And my master's thesis was essentially on racism and hypertension care. There are a couple of papers out there in the literature, some of the first papers on racism and care delivery in the United States. And we found that African American males in Eastern North Carolina in our study site had the worst hypertension. They also had the least adequate pharmacotherapy prescribed for them, and they were less likely than white patients to receive a follow-up appointment. So I realized that there were system issues that also led me in medical school. I directed the Student Health Action Coalition Clinic. Many of you are probably familiar with that. That was started in 1966. It's the oldest student health run clinic in the United States. Schools of medicine, pharmacy, nursing, and public health. And when I was a student, also we had a dental clinic too. Ron Strauss was actually our overall faculty advisor. So I learned a lot about unmet needs by working at Shack Clinic. I learned a lot about disparities in care, and also learned about the importance of collaboration amongst nurses, physicians, pharmacists, public health folks. So as I was finishing my initial 4 degrees at UNC, I knew that I wanted some clinical training, and my mentor, Ed Wagner, who ran the Robert Wood Johnson Clinical Scholars Program, told me, he said, David, you're going to have to figure out ultimately what role clinical care is going to play in your life, because to do what you want to do, leading healthcare systems, having a global influence on healthcare through writing and teaching and mentoring, you're going to have a tough time really being somebody's primary care doctor. And said, David, out of 16 general internists at UNC, there's one person in our group who's actually somebody's doctor, is Jim Bryan. Some of you may have known Dr. Bryan, just a lovely human being. So long story short, I decided, I looked all over the country, unlike medical school where I said, I'm just going to stay in Chapel Hill, applied early decision, been there, done that. I looked at like 50 programs across the US, and I was absolutely struck the 2 days I spent in Rochester, Minnesota at the Mayo Clinic. After spending 2 days there, I was convinced that that was the best place in the world for healthcare. And I wanted to be trained by the physicians at Mayo Clinic. So I ended up ranking Mayo Clinic #1. And maybe just to give you a snapshot of what's kept me passionate about healthcare. So I'm like a lonely intern. One of the safety features at Mayo Clinic was internal medicine residents would evaluate surgical patients as an extra safety measure to see if they had issues before surgery. So I was asked to see a neurosurgical patient by, this was a patient of the guy at that time was probably the most famous neurosurgeon in the world, Thor Sunt. Thor sadly died in his late 50s of multiple myeloma. If you go to West Point, there's a room at the Thayer Hotel dedicated to Thor. He was a hero at Hamburger Hill in Korea. Incredible person. Well, I see that I had a lot of admissions, and I didn't get around to seeing Thor's patient to do the pre-anesthetic medical evaluation until almost midnight. And it's like 1:30 in the morning, and I realized this patient probably has significant coronary artery disease that no one has worked up. So I say, what do I do? Am I going to call the most famous neurosurgeon in the world at 2 a.m. and tell him that I'm not going to okay his patient for anesthesia? I'm a lowly intern. I call up Dr. Sunt at his home. He answers the phone at 2 a.m. and I describe to him my findings. And Dr. Sunt says to me, thank you for your very careful evaluation. I really appreciate it. We'll take the patient off the list. We'll have cardiology do a full evaluation of this patient before we do surgery. That's the kind of care that's really unique at the Mayo Clinic, but many other examples I could share with you as well. But we have other topics we're going to move on to. Yeah. Megan, you're on mute, I think.
There we go. That's wonderful. I always find it fascinating to hear your stories. And I think the stories early in our careers and then the pivotal moments throughout our careers shape us in such transformative ways. So let's move on to our first topic area, which is the U.S. health system. And if you think about as we approach the U.S. healthcare landscape, we're thinking about public and private, thinking about providers and payers. Dr. Ballard, share with us how you're seeing the shift in care delivery models, the financial stability, the outcomes, and And in particular, not necessarily the mechanics of it, but the application from the stories that you've seen throughout your career. I know some of the attendees tonight asked some questions about how to navigate nonprofits and federal funding in context of 2025, but most excited to hear your stories of application around the overall healthcare landscape.
Sure. And you know, we have some slides in the appendix that go into great depth that we decided not to put in the middle of this because we didn't want to get really distracted. And this slide here, you know, would be fairly textbook language about you have public systems, you have state and local systems. My career has really been in very large healthcare systems, Mayo Clinic initially, then the University of Virginia, then Emory Healthcare, and then Baylor Scott and White Health, the largest healthcare system in Texas. So you know, there's a very broad spectrum of public and state and local. Many of you work in these environments, and I guess what we'll get into as well is we have private systems, and private systems have some complexity for profit, not for profit. But even within not for profit, you have some for profit entities. So there's really a broad landscape of healthcare in the United States. And I noticed today David Chulkin was on LinkedIn trying to encourage people to consider being the Undersecretary of Health for the VA. That David was in that role, and I guess they're seeking to appoint someone to that role now. So Megan, I don't know if you wanted to have any other comments about this matrix before we move on.
No, I think the fact that you know, you've had experiences around both. I've had experiences majority in academic medical centers, and I find that if you've seen one academic medical center, you've seen one academic medical center, similar to all of these different categories. So I think a lot of, as much as you can detail out I mean, ownership is important, right? And the direction of the board is important. But yet it's not just about the technical pieces of the organization, the culture, the leadership. And Dr. Ballard, I don't know if any piece about the leadership, if you want to highlight, because we had some slides around not-for-profit and for-profit, but again,
Sure. So this slide
similar
here,
to the leadership. Yeah.
so this slide here is kind of, you know, could be textbook language. And, you know, if you work for a for-profit healthcare system, I'm sure you're going to argue that you're mission-based as well. And I would agree with you. Jonathan Perlin, when he ran HCA as the chief clinical officer, would argue that HCA paid as a percentage of its revenue had more free care it provided than not-for-profit systems. So you know, there's not purely for-profit, not-for-profit. I served on the board for 10 years of a heart hospital up in Plano, Texas. That hospital is a component of Baylor Scott and White Health, but doctors own 49.5% of that hospital. Baylor Scott and White Health owns 50.5% of that hospital. I think roughly over $1 billion in revenue, 25% operating margin. So for the doctors, that's really a for-profit hospital. Baylor, for the hospital side of it, the investments are the profits are invested back into the community. There aren't shareholders of Baylor Scott and White Health Hospital per se. It's a community resource. And then, you know, one could have a much more extensive discussion about, you know, should not-for-profit hospitals be taxed? And of course, I guess Trump's raising the question of whether Harvard University should be taxed. So you know, there's I would say that with the advent of models within not-for-profit systems, so Baylor Healthcare System, before Baylor merged with Scott and White in 2013, Baylor had over 100 joint ventures in healthcare. And that was because Baylor felt that Baylor Healthcare System felt that they didn't do everything better than everyone else in the marketplace. And in some cases, there's this question about vertical horizontal integration. In some cases, Baylor Healthcare System decided to partner with other for-profit organizations, creating for-profit joint ventures within a not-for-profit. We also had a for-profit. We had a joint venture with Select, which again, the Baylor Scott and White Health component of that was a not-for-profit component.
I think a big piece that I've picked up is whichever type of system you're working for. Again, I've said if you've seen one system, you've seen one system, but it all comes back to ensuring the alignment of incentives, the alignment. I think all healthcare is patient-centered. It just goes about it a different direction, possibly, and that alignment of incentives makes a big difference.
And this comment about investing in technology, sure, not-for-profit, the for-profit systems could go to the investment market for that purpose, but one of the reasons that organizations like Baylor Scott and White Health are interested in their financial performance, I think Baylor Scott and White Health has a margin of 8.5% right now, is that allows them to then invest in new technology, new procedures, new care models. Also, as many of you know, your margin and your days cash on hand and other elements of your financial performance influence the interest you're going to have to pay on your debt. And so your debt's going to cost you a whole lot less if you're performing well financially as a not-for-profit.
And when you're giving away free care, I don't think it's just free care. It's making decisions about how your entire care model is structured to serve the community. And that may look different in each system as well.
Yeah, so one example, and I'm sure those of you who are on this Zoom have experiences as well, but one of the things about 18 years ago or so, we had patients who were having about 300 visits a year to our flagship hospital downtown, Baylor University Medical Center. We actually built in Dallas, in inner city Dallas, a residential community and staffed it with a nurse to provide housing for those individuals. It cost us less money to do that than to have those people come to our ER 300 days a year.
So then as we transition to the different sites of care, and how does the administration of healthcare impact, how has that impacted your career, and what highlights come to mind?
Well, I mean, this may, certainly very simplistic, but so, you have these academic health science centers that, have historically, they've evolved out of medical schools, hospitals connected to medical schools, medical groups, maybe faculty practice plan. So then when I went to the Mayo Clinic, when I went there, Mayo was a group practice. In 1986, as I was joining the Mayo Clinic staff, Mayo Clinic actually acquired Rochester Methodist Hospital and St. Mary's Hospital. So until that time, Mayo Clinic was just it was a not-for-profit foundation that the Mayo brothers founded in the early 1900s. So you have these historic medical groups that have become healthcare systems like the Mayo Clinic. I mean, Geisinger, the Geisinger, as you probably know, was bought by a private equity entity, Resont, recently, and Resont also bought Moses Cone Health System. But you have like Cleveland Clinic, Mayo Clinic, Ochsner would be another example of clinics, of healthcare systems that evolved out of medical groups, acquired hospitals, and then have become very large delivery systems, and many of those have large health plans as well. And you have these other medical groups. You have these huge private equity-backed medical groups. You have Optum employs more physicians than anyone in the United States. You have huge medical groups that are connected. Like, for example, McKesson is a management company linked to my wife's practice, Texas Oncology, 600 partners, oncologists in Texas Oncology. So there's a lot of diversity across the United States in these various models. And I would say that it depends on the market and what makes sense in a given marketplace. And what the Mayo Clinic can do in Rochester, Minnesota, it's probably not going to be able to do in Dallas, Texas, given the dynamics of the marketplace in Dallas. Yeah.
And
Again, I don't know if you had any other comments about this.
I was just going to intervene real quickly so that we could pause to see if we've got any questions from our audience. Again, audience, just to remind everybody that you can raise your hand. I do have real quickly, because I think that this audience member can't get on camera right now, but I'll go ahead and read it from the chat. Dr. Ballard, thank you so much for joining us. In business school, we learn about the cost, access, quality iron triangle. The premise being that it is challenging for health systems to balance these three priorities without feeling like they're facing some trade-off. Given the growing vertical and horizontal consolidation occurring in the healthcare industry, what are your thoughts on how business leaders across insurance, hospitals, pharma, etc., can still center the patient experience to provide affordable, accessible, and quality care?
Well, I'm not going to be so naive as to say that the best quality of care is the lowest cost of care, but certainly the pursuit of quality is about waste reduction. And so, for just as an example, in my own experience in the Dallas marketplace, this hospital in Plano, the Heart Hospital Baylor Plano, 2,000 cardiac procedures a year. They actually, if you actually measure their cost to produce a coronary artery bypass graft surgery, it's a whole lot less than it is for much lower volume hospitals, and their risk-adjusted mortality experience is better. Their patient experience is great because they provide a single room for the patients through their whole episode of care. So I think I don't think that these are necessarily trade-offs of cost, access, and quality. Often if one can provide better access, one can engage care at a point where you can avoid the cost of complications. And I'd say, one thing that's probably different about care today than maybe it was 40 or 50 years ago is, with payment for outliers and whatnot, essentially hospitals get paid to create complications. And today that's no longer the case. So I don't see that these are, if you will, sort of competing goals. I think, that the quadruple aim of care is what we're all pursuing. We're pursuing minimizing cost at a population level, optimizing healthcare outcomes, optimizing the patient experience of care. And my undergraduate, my advisor in medical school and School of Public Health, Ed Wagner, was the one who really realized you needed this fourth aim about joy and caregiving to address the other three aims. So I think whether you're in an insurance company or hospital or pharma, you need to think about the quadruple aim of healthcare and how can you contribute, because to be successful in the healthcare marketplace, you're going to have to do something positively with respect to the quadruple aim of care.
Terrific. And I just want to mention that was from Kara Griffith, one of our MD MBAs. And we're still open for questions.
I have a brief question here. Hi, Dr. Ballard. My name is Bradley Boaz. I'm a first-year MBA candidate at UNC Kenan-Flagler. Thank you again for your time here. Question focused on hospitals. So we've mentioned some standout hospital systems being Mayo Clinic, Baylor Hospital. Curious about hospital systems throughout the U.S. that are struggling, that is experiencing shutdowns. So want to hear your thoughts. What do you think is contributing to hospital shutdowns? And then from a business lens, how do you see private equity and venture capital playing into these shutdowns?
Well, and many of you probably know the HCA model much better than I do, but early on the view was that HCA went into communities, bought up hospitals, and shut down sort of there was some excess capacity in some communities. I mean, I'll give you a sense of my own experience. Okay, so one of the things that I wanted to do was I wanted to make our care as safe as possible across all of our acute care hospitals. And we had a hospital in Plano that did 2,000 cardiac surgeries a year, had better STS performance metrics than the Cleveland Clinic flagship hospital, which was #1 in volume. They're about 2,100. But we had a hospital, and I won't mention the community. I'll just say the hospital's closed now, but I just want to give you a feel for how this plays out. This hospital was only doing 50 cardiac surgeries a year. It was only 15 miles from the hospital in Plano, 15 miles from the hospital downtown. And I felt like we shouldn't be doing cardiac surgery there. I could not convince any of my colleagues to agree with me. They said, you don't care about the viability of these community hospitals. I said, no, I care about where I'd want my mother to have cardiac surgery. We weren't able to make the right decision about their cardiac surgery program until a Friday afternoon. They decided to do a case. The patient needed it was a CAB, it was supposed to be a coronary artery bypass graft. Turns out intraoperatively, the patient needed a mitral valve. Guess what? There was no mitral valve in that hospital. Somebody drove a mitral valve from Plano down to that hospital. By the time the valve got there, it was the wrong size. By the time they got the right size valve from Plano down to that hospital, again, I'm not going to identify the community, that patient was dead on the table. So it took an event like that to recognize that we shouldn't have a cardiac surgery program in that hospital, and probably, given all the other hospitals we had as a multi-hospital healthcare system, we probably didn't need that hospital either. And that's no longer a hospital today. So I think there's real challenges around small community hospitals. And I'm talking about an urban area where there are many, many other options. Obviously, this is more complex in a rural area. But I think that it's a great question. I was involved with, helping to lead initially Baylor healthcare system, a system that was mainly in a metropolitan area. And a lot of what we were trying to do was to try to think through, given the assets we had, what care should we provide in which hospitals?
To add to that from the North Carolina landscape, when I was at Wake Forest, we had a lot of close interactions with hospitals we both were in the middle of acquiring, and also hospitals that we never planned to acquire, but we could have different kind of partnerships to provide care. So I've seen very purposeful care delivery decisions that did not include purchasing, but really boosting that hospital up and helping keep the care in their community, because I think that's where we all benefit. Our goal at Wake Forest was to, if a patient left the county, for them to come to us, but let's keep them in their county. Now, to your point, a lot of the financial challenges, but then you also have some safety net hospitals that are doing incredibly well. Working with a group in Astoria, Oregon. Are y'all too young to know Goonies? Who knows Goonies, the movie? So or Kindergarten Cop, that scene at the end, but you have a safety net hospital there that's getting ready to build a whole nother tower, and great technology. They have surgery in the community. You then have like Boston Medical Center that's recently acquired 2 new hospitals. And I want to say Brockton and Brighton. I may be wrong, but in Boston, because they've realized these hospitals can't succeed without joining a larger system. So to add to that, I do think there's benefits of increased quality, but yet and we'll talk about mergers and acquisitions and some other collaborations in the next section. So this ties us perfectly.
But so many of there a lot of attention to the relationship between volume and outcome in healthcare, and sort of this list of surgical procedures for which there's very good evidence that higher volume relates to better outcomes. One would be the Whipple procedure, pancreatic resection, that great data from the state of Maryland and other data. So, similar deal. We had a hospital that was doing 150 of them a year. We had another in a relatively rural area that was doing like 4 or 5 a year. And somebody was arguing, well, we think our patients would rather have care close to home. Really? You're going to try to do 4 to 5 Whipples a year? when you're part of a system where you have a hospital that does over 150 that has great outcomes. So I think this thing about, what patients want, uh, uh, you know, patients want safe care. And unfortunately, a lot of patients aren't aware that care might not be delivered very safely in some of their environments.
Let's flip on to that next question of the patient. And Dr. Ballard, what are you seeing? I completely agree with you that some patients aren't aware of what they need, and what are you seeing in across our health system that's impacting the patient, and what shifts do you feel are most critical to better serve the patient moving forward?
Well, I mean, you're seeing a lot of consolidation in care, and you're seeing, you see patients who, I mean, you could argue the insurers are really the entities that steer the patients, right? And so the issue is, okay, so what kind of access do patients have? So my wife's part of Texas Oncology. Texas Oncology controls the cancer care market in Texas. They have 70 cancer centers across Texas. Blue Cross Blue Shield has tried to exclude them from contracts in the past, and Texas Oncology says, our patients need our care, and ultimately the insurer will do what they need to include Texas Oncology in a offering for a corporation because it's a must-have. So from a patient perspective, you hope that you're connected to insurance that provides you with some safe options that amongst various options are as affordable as they might be. But um, there's no question that you have this struggle between insurer. Of course, you have healthcare systems that have their own health plans as well, but you have insurers that and at some level driven also maybe by employers that want to have narrow networks. And then the question is, who are they going to include in those narrow networks? And so again, if you're a healthcare system, you want to be a must-have provider for any insurer in your geography. And so, I think patients, there's a lot of forces that steer where patients are going to receive care, and fully informed patients might end up receiving care in different settings than they currently receive care. That's the reality of the U.S. marketplace.
This next slide is more just the pieces that impact the patient care or impact the patient. Rather than focusing on this, Dr. Ballard, what other thoughts and insights do you have around how you've incorporated the impact on the patient in some of the quality work you've done and as a leader?
Well, I guess again, one message to say Baylor Scott and White Health over I was the chief quality officer for 19 years, over 1,000 locations across Texas, was to say, there's some care we can provide in your community that we can provide in Marble Falls, Texas, as well as we can provide anywhere. But if you need a complex valve procedure and you happen to live in Marble Falls, we're not going to be doing that procedure in Marble Falls. We're going to be doing that in one of the hospitals that does a couple thousand cardiac surgeries a year and many mitral valve surgeries, and has the evidence to document that they're a safe place for that procedure. Certainly there's challenges around staffing in rural areas, and so any large geographic based delivery system like a Baylor Scott and White Health has to look at also the role of advanced practitioners in addition to physicians, staffing those areas and having everyone work at the highest level of their license to be able to provide care and make care accessible, throughout the organization.
One thing that's been very much in front of me is I've been working on a recruitment of a pediatric surgery leader in Colorado, and then working on a surgical oncology leader in working with that in Utah. And seeing the states that only have one academic medical center and seeing how far the patients are willing to travel. Again, the quality of care is there in the academic medical center, but seeing that impact on the patient. And I would just challenge those of you who are already in the field, and then those of you who are entering the field, anytime you have a business plan, make sure somewhere someone says, pause, what's going to be the impact on the patient from this? And we can't always make every stakeholder happy, right? But at least to identify what is the anticipated impact and what would be done about it.
So, one of the mantras of my wife's group, Texas Oncology, is quality cancer care close to home. That's one of the reasons why Texas Oncology has 70 cancer centers across Texas. And it's also why they provide free transportation for their patients to be able to receive radiation therapy or, in-facility chemotherapy in one of the 70 clinic sites. So yeah, I think if you're going to be successful as a healthcare organization in 2025, you have to figure out how to deliver care that's accessible to people. Yeah.
Absolutely. So going to the question that was part of the Q&A on what is the I believe it was talking about the iron triangle and the challenges to health systems and how do we balance these priorities. Of all of those thoughts that we've said already this afternoon, and also Dr. Ballard, what you've seen, what do you think are the most urgent, or what do you see as the most urgent challenges facing health systems? And then what are some examples of how organizations are responding to those pressures?
Well, I mean, there's huge problems with chronic illness care in the United States, right? And how to help people with chronic illness, but how to help people live healthier lives. There's the need to continue to find ways to deliver care in the least costly environment. I was mentioning this thing about joint ventures in healthcare, and sort of the 20 years ago when Baylor Healthcare System did all these joint ventures. The idea was we can't do everything better than everyone else in the marketplace, and so, for example, did a joint venture with an imaging company because the sites that Baylor Healthcare System and Baylor Scott and White Health had for imaging were just way too expensive to maintain. This company, Touchstone, had better geographic distribution for their imaging in communities across Texas. They also knew how to manage imaging and how to manage cost. And so that business turned out to be much more effective when Baylor Scott and White Health created a joint venture with Touchstone Imaging to leverage the geographic scope of Touchstone and the management insights. So I think that's kind of one of the challenges of some healthcare systems that are used to doing everything on their own and don't ever want to partner with someone. Is it's highly unlikely that you're going to do everything in healthcare better than every other participant in the healthcare marketplace. And some organizations like Baylor Scott, one of the reasons why it has a 8.5%, 9% margin is it is able to work nimbly to identify partners, like, for example, Select Medical in the physical medicine and rehab space. So I think one of the challenges perhaps for academic health systems is they're probably historically have had their own kind of approach to doing things, and they haven't been as comfortable with a variety of business relationships for care delivery, leading to a much higher cost model.
What do you think about the Duke UNC partnership around children's hospitals?
And some of our Zoom attendees here may have some insights about that. To me, I think it's a great idea. I don't, with pediatrics, care is the sort of thing where communities, I think, have pretty much figured out, for the most part, you probably shouldn't be competing in children's health care. And you ought to be figuring out how. I don't know what thoughts you have, Megan. You're based in North Carolina, and
I think Duke and UNC have a unique situation because of such close proximity. At Wake, we were further away from other academics. But I agree with you. I think, pediatrics often is a loss leader as a whole service line. And I mean, not a loss leader, that's not the right terms, but like is a service line that's not as high profit or contribution to margin generating. And so I think if the two can come together and provide greater financial sustainability for both organizations within the service line and better care to the community, I think it's a great, and that's where, as Dr. Ballard, as you and I were putting this slide together, we talked about the compete or align. It's a continuum. Like, it's not always acquire fully. It may be a different type of collaboration, like to the right on this slide.
Yeah, that's so I think, and that's one of the great things about going through Keenan Flagler Business School academic program, and the the opportunities you have to apply these to projects is to think about what are some out of the box models to that challenge your historic way of doing business. Again, I think that the healthcare systems that have historically been kind of monolithic, that have pretty much called the shots in terms of how they provide care without really in any significant collaboration or mergers with other healthcare marketplace organizations. That model's very challenging because, again, you're sort of isolated in the marketplace, and you're probably not well positioned to take the best business ideas into your organization.
I really have enjoyed watching innovation quarters develop too, in collaborations with health systems. And there's also a piece that this is way beyond our scope today, but there's a piece around economic impact, right? Like both how much the states are investing, but also how like the cost of the UNC Duke project, and also the number of jobs it brings. There's an economic impact piece too that's always.
So, Suzanne, I think we need some comments or questions from our colleagues here.
Absolutely. So please, Farjan, raise your digital hands or type if you can't get on. Ready? Walter, go ahead.
Hey, can y'all hear me all right?
Yes.
Okay. First of all, I want to say thank you so much. And my question was about consolidations of hospital systems. I'm curious about how that can affect the patient, and if those transfer from one hospital system to another can be really messy, or if that can be seamless.
Well, in terms of, sort of what I've observed through consolidation is patients in a given community, say isolated rural community, through consolidations, they can have access to care they have a very difficult time accessing with someone from, some very small town in rural Texas can end up in Plano Heart Hospital and have surgery in the safest environment in the United States for cardiac surgery. And that it could happen rapidly because of the focus on systemness and on, how do you move patients across the system to get them into the best site of care for them as rapidly as possible. Yeah, I'm sure UNC Health does this kind of thing. And so, and then you had sort of this question about, well, what if you have, I guess, competing, say, hospitals and about movement of patients between them? I think that kind of depends in certain markets, like in a place like Dallas, where historically you have medical groups that go across hospitals, the specialty groups that aren't employed by hospitals. Those specialty groups quite naturally would identify where's the best place for particular type of specialty care, regardless of whether the hospital is owned by HCA or Tenet or THR or Baylor Scott and White Health. So you do have those medical groups that sort of, and so as an example, for example, with my wife's group, Texas Oncology, they cover all the hospitals and cancer care in Texas, and they know that there's certain partners in Texas. Like there's one colleague of my wife's who's she's brought more molecules through the FDA process for breast cancer than anyone in the world. Well, if you have a very tough breast cancer case, regardless of whether you're at, the HCA hospital, you're probably going to send that tough case to this particular physician who happens to work out of Baylor University Medical Center in Dallas. So it's one of the things that helps, where you have hospitals that compete with one another, are medical groups that actually work across all those hospitals.
And
Thank
one
you.
example locally, the weekend when High Point Hospital moved from UNC to Wake Forest, I was actually the administrator on call for the system. And so even though I had watched it in preparation from a heart and vascular perspective, I got to see it that weekend. I would say once it gets time for the actual acquisition, there's been so much planning that all of those pieces have been considered. A lot of pieces around patient billing, a lot of just detailed. Also, usually when you get to the point of acquisition, both at that point, UNC was ready to pass off High Point Hospital, right? And Wake was ready to pick up that ball. So it was, I would say, I first person witnessed it being as little as possible impact. Of course, there's going to be hiccups along the way because it's such a large project. The other piece I've seen is with the amount of funds that are invested in those hospitals. It tends to benefit the patient, which Dr. Ballard was mentioning about as well. For example, when Wilmington, New Hanover Hospital, in that proposal, the reason why Novant won that proposal was the amount of funds they committed to investing in the capital plant. Similar for Wellstar down in Georgia, they had a very purposeful expansion, and most of those acquisitions were around a commitment to invest funds. So oftentimes the patient wins for a number of reasons, and some of that's the logistics, but a lot of times it's the funds invested in the capital plant as well as the.
So Suzanne, I know we're about to run out of time. I realize we haven't said much about private equity, but we had a whole private equity conference at the National Press Club in DC about 4 years ago to that Center of Business Health. I'll just say this quickly. So you have hospital-based systems and private equity groups that are competing for physician groups. You got medical groups that want to be independent, like my wife's group, Texas Oncology. There's no way in hell anybody's going to buy Texas Oncology, any hospital system. You got 700 partners in that group. So these forces are out there in the marketplace, and in some places like Rochester, Minnesota, you can have a Mayo Clinic that can be everything. But in a market like Dallas, Fort Worth, or some other markets, there's going to be all sorts of models out there, because in some cases you have incredibly strong independent medical groups that are going to be independent. In other cases, you get a lot of influence from private equity. In other cases, you have hospital systems that are, or you have Optum very active in certain geographies with respect to physician ownership.
And then before we take the final question, Dr. Ballard, anything to add in terms of the potential impact for our audience?
No, I mean, this may seem really trite, but one of the things that brought me into healthcare was a realization that the healthcare marketplace in the United States is so inefficient. There's just huge opportunities to make a contribution to improve care. And that's been my experience over my career. And that's one of the attractive elements of working in healthcare.
Terrific. And thank you so much, first of all, to Walter for his question and your thoughtful answers to that question as well. And also, we have one additional question in the chat from Emmanuel, who is one of our undergraduate minor in the business of health students. Considering the increasing focus on value-based care, what dynamic shifts in payment models and performance measurement are driving healthcare organizations to fundamentally change their approach to cost management and quality improvement? That's a big question. So let's see what we can do in 4 minutes.
So that's a huge question. Megan may have some comments. I'll say, Dr. Oz is very interested in this. Those who look at LinkedIn, David Shokin had a LinkedIn comment yesterday about his recent meeting with Oz about Oz's ideas with Medicare. But for example, I was just sharing with you, one of the things that drove Baylor Scott and White Health to partner with Touchstone was that the ACO of Baylor Scott and White Health said, the physician said, we're not going to send our patients to the Baylor Scott and White Health hospitals for imaging. It's way too expensive. It costs too much money. We're missing out on shared savings. We're going to send them to Touchstone facilities where they're going to pay a fifth or a tenth of what they're going to pay for a hospital-based MRI. So that would be an example of some dynamic shifts that change the way healthcare systems partner in the marketplace. But
sure.
that's a great question that could be a whole topic. But Megan, you probably have some thoughts about this.
Great example on that. And I do think this all comes back to, and it's how you phrase the question. You talked about cost and quality, and that's the value equation. And that's what, Dr. Ballard, you've been doing throughout your career. It's impacting both. I don't think you can look at just one without the other. So I've enjoyed hearing your stories tonight, Dr. Ballard.
Excellent. And I see we're kind of getting to time. So just since we do have 2 minutes, I know you kind of went over your kind of thoughts moving forward. Can you just add maybe 1 minute each about what our audience members should kind of focus on? I know you kind of said there's going to be a lot of opportunity. Can you each pick one that might be highlighted?
Well, again, I talked about the quadruple aim of healthcare, and regardless of where you are in the healthcare marketplace, if you're trying to bring solutions to the market, they have to do something about reducing population level cost of care, improving the patient experience, improving health outcomes, or optimizing the joy in caregiving. You've got to focus on bringing value in one or more of those dimensions to be successful.
Megan?
I usually would say something a little softer, but I'm going to go a little more technical and say no margin, no mission. And ultimately figuring out how to make the margin work so that it can drive the mission. I think this year, especially in the impact financially, but healthcare looks totally different than it has. I mean, it's changed rapidly, but it's even more rapid this year. And figuring out what are the new partnerships or those relationships, but also what are new funding sources and how can it look like in the future, but in a way that's financially sustainable, because oftentimes value-based care has been tough to achieve in bundled payments and such. And so figuring out how to make the margin work.
Terrific. And again, when talking about value, this was such a valuable presentation tonight. And thank you First of all, to Dr. David Ballard and Megan Berlinger for joining us tonight. And also thanks to all of our audience members who did as well and asked such thoughtful questions. Again, you can reach out to both Dr. Ballard and Megan via LinkedIn or through our Career Networks platform. And I also popped in for next week. We'd hope to see you join us next Tuesday for a follow-up. So again, to thank everyone tonight, and hopefully we'll see you next week.
Great. Thank you, Suzanne. And I'll be in the southern part of heaven, the April 29th to May 1st, and I have a little bit of free time. If anyone wants to connect with me, then just reach out to me and we'll see what we can make happen.
Awesome. Everybody have a great night. Thanks so much.
Thank you so much.
Thank you.